Good afternoon, everyone. I'd like to welcome you to The Exchange, Critical Conversations with Michigan Public Health. I want to thank all of you here for braving the cold and coming to join us in person. We also have people joining us by live stream, so I want to acknowledge your presence and thank you for joining us as well. Also want to extend a warm welcome to Dr. Rachel Levine and our esteemed group of panelists who you'll hear from later. The Exchange is a new seminar series that we recently launched with the primary goal of trying to create a space where scholars and students from Michigan Public Health and across the university, external stakeholders, and those community partners can convene just to discuss pressing public health issues, to be able to exchange ideas, and ultimately to influence and accelerate a course of action to create a healthier, more equitable world for all. The theme of today's event, health and gender equity in the modern era. Today's event is closely tied to a research initiative that we have in the School of Public Health here at the University of Michigan called Public Health Ideas, where IDEA stands for Interdisciplinary Discovery, Engagement, and Actions for Society. And over the last few years, we've launched IDEAS, and we have 4 areas of focus under IDEAS. It's public health ideas for creating healthy and equitable cities, public health ideas for preventing firearm injuries, public health ideas for combating infectious diseases, and public health ideas for building health equity. So today's event specifically aligns with that last one, building health equity, which is led by Dr. Justin Colosino and Dr. Enrique Neblet. So let's give them a hand for the work that they're doing. And I also like to include Sarah Cadis for her support in that work as well. So we have a fantastic event planned for today. For those of us in public health, we know that gender is a really critical determinant of health, and a person's gender can impact their access to health care, the quality of the care that they received, and their overall well-being. We also see how policy shapes access to the care that might be available depending on one's gender. And we see this playing out right now at the federal level, but also at the state level, and when we talk about states, in ways that vary significantly across states. We will begin with a keynote speech from Dr. Rachel Levine. Following that, she and I are going to sit down and just delve deeper in conversation on today's topic, and then you'll hear from the tremendous panel of experts who will discuss work going on in Michigan on the ground, and then also some of the ongoing research taking place here at the university. After that, for those joining us, we will have a reception, so hopefully your schedule permits. It's a lot warmer in here, so stick with us for a while and join us for the reception following today's program. I want to once again thank the presenters and participants. Thank you to the marketing and communications team who does a fabulous job of putting this together, and for all of you in the audience for joining. So with that, let's move into our keynote. I'm thrilled to have Dr. Rachel Levine with us to deliver the keynote address. Admiral Rachel Levine, MD, served as the 17th Assistant Secretary for Health at the U.S. Department of Health and Human Services and led the United States Public Health Service Commission Corps. Prior to Dr. Levine's federal service, she served as Secretary of Health and Physician General in Pennsylvania, where she led the state's response to the acute phase of the COVID-19 pandemic and also the opioid epidemic. She entered public service in 2015 after a career in academic medicine, including as a professor of pediatrics and psychiatry at Penn State College of Medicine. She's received and been recognized by many honors and awards. She's a fellow of the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, the Academy for Eating Disorders. She also served as president of the Association of State and Territorial Health Officials, and Dr. Levine is a member of the esteemed National Academy of Medicine. In 2022, she was recognized by USA Today as the 2022 Woman of the Year, and then by Time magazine as in the inaugural list of 100 most influential climate leaders in the world. Dr. Levine, we're delighted to have you. Thank you so much for joining us, and I'll welcome you to the stage.
Well, good afternoon. Thank you so much for that wonderful introduction. And I am very pleased to be here at Michigan Public Health. As you just announced, so I am Rachel Levine, she, her pronouns, and I've had the incredible honor of serving as the Assistant Secretary for Health at the United States Department of Health and Human Services, and as a 4-star Admiral and head of the United States Public Health Service Commission Corps throughout the Biden-Harris administration. I actually did not plan to work in government and in public service in my career. And as you mentioned, I was really quite well ensconced in pediatric academic medicine at the Penn State College of Medicine. And it was really quite a surprise for me when I received a phone call from Pennsylvania Governor Tom Wolf when he was elected, when he asked me to be his physician general. But I said yes enthusiastically. And we got to work responding to the opioid epidemic, increasing childhood vaccinations, and advancing the quality of care for LGBTQIA+ Pennsylvanians. The opioid epidemic was and still is very challenging for local, state, and federal public health. But with all challenges come opportunities, and it is an opportunity for collaboration across ideological lines. Opioids and other illicit drugs, such as methamphetamine and cocaine, are still causing significant numbers of overdoses and death. In Pennsylvania, there were many policy levers that we pursued in regards to prevention, in regards to recovery and harm reduction, and in terms of retreatment. One of the actions that I took was to sign a standing order prescription, allowing law enforcement and all first responders to carry naloxone, and another standing order prescription for everyone in Pennsylvania to obtain this overdose reversal medication without a specific prescription from their physician. Policy actions like these work in combination with efforts in public health to advance health promotion and disease prevention. They also require implementation efforts, for example, to train law enforcement on how to administer naloxone and how to promote the idea that people can and frankly should carry naloxone, and encourage others, especially in public health, to do so as well. When I got to Washington, my office partnered with the United States Department of Housing and Urban Development on an innovative policy to allow naloxone in public housing, and with the General Services Administration to place naloxone in every federal building in the United States. Now, after serving as Pennsylvania's Physician General, Governor Wolf nominated me to be the Secretary of Health. And I remember coming back and talking with my dear mother, who at that time was around 95, she's since passed, and saying, you know, Mom, I'm going to become the Secretary of Health of Pennsylvania. Now, you know my upbringing when she said, honey, that is absolutely wonderful. You know, that could lead to something. I thought it was something, but you know, my mother thought it could lead to something. Now, of course, what none of us knew at that time was that our nation and our world would soon be thrust into the darkness of a global pandemic on a scale that we had not seen in 100 years. But public health requires the ability to pivot quickly to address the urgency of every moment. And so at Governor Wolf's side, we announced COVID-19 containment efforts, mitigation efforts for our state, and held daily press conferences with transparent updates to keep our communities safe from this novel, dangerous virus. Now, medical countermeasures arrived at the very end of 2020 with safe and effective vaccines. And our public health strategy was sound. But as you know, politics started to get very heated a few months into the pandemic, and our communities started to divide, with pent-up anger about how our lives had changed so drastically. This happened in Michigan. It also happened in Pennsylvania. And in Pennsylvania, a lot of this anger turned into public displays of transphobia and bigotry. Now, I had been confirmed unanimously by the Republican-led state Senate in Pennsylvania twice, and close to unanimously a third time. Throughout my public service, I have been out as a transgender woman, and I have spoken publicly about LGBTQI plus health. But until this moment, I really did not experience a lot of vitriol. But at this time, things got quite ugly. Now, bullying is also a public health issue, and while we were giving daily briefings to keep our communities across Pennsylvania safe from COVID-19, transphobic zealots started to fill the live stream comments with anti-trans sentiments. So on July 21st, 2020, at the start of one of my daily briefings, I talked about how important it is to stand up to bullies. And I wanted all transgender Pennsylvanians and their families to know that we do not have to accept transphobia, and we can and we must call it out and stand up to it. For many Americans, COVID-19 was really the first time that they understood issues of public health and how important public health was, and the critical importance of health equity. Healthy People 2020, which was also in my portfolio, defines health equity as the attainment of the highest levels of health for all people. Now, at the beginning of the COVID-19 pandemic, it was clear that all people were not able to access care or prevention strategies equitably. Early in the pandemic, the CDC directed states to start tracking racial disparities within COVID-19 infections and mortality. And there was an early recognition that health disparities would leave some communities more vulnerable to the risk of COVID-19 and to the worst effects of COVID-19. And so specific actions were taken at federal and state levels to prioritize health equity because how vital and fundamental it is to public health. Now, there are some people today suggesting that health equity is woke or somehow divisive. But if we have learned anything from COVID-19 and the opioid crisis as well, it is that health equity is vital and fundamental to public health. I am proud about how we prioritize health equity in Pennsylvania's response to COVID-19. We prioritized health equity in our testing efforts and in our vaccine distribution efforts. And we were the first state to collect SOGI data, sexual orientation, gender identity data, for COVID-19 tracking. Now, in January 2021, President Biden asked if I would serve as the Assistant Secretary for Health. So I guess my mom was right, because serving as Pennsylvania Secretary of Health led to being the Assistant Secretary for Health in the United States. My mother was always right. And so this did lead somewhere. Actually, got a text one night in January, literally about 10 o'clock at night. I was sleeping, of course. And, would you be interested in a position in the Biden administration? And the response was, well, yes. And amazingly, within a couple of days, that led to my being nominated as the Assistant Secretary. And it was an enormous honor to be asked to serve our nation. I proceeded through the confirmation process, which was very interesting, and received bipartisan confirmation to serve as the 17th Assistant Secretary for Health, and I took my commission as an Admiral in the United States Public Health Service Commission Corps. Now, I want to talk for a moment about the United States Public Health Service Commission Corps. It is one of the 8 uniformed services. You have the armed services, and including the Coast Guard, and then you have NOAA, and you have the United States Public Health Service Commission Corps, which reports to the Secretary of Health and Human Services. It is the only uniformed service dedicated to protecting the nation's public health in the world. We have more than 5,500 officers that serve in 800 different locations across all 50 states and numerous foreign duty stations. They serve across government, including by providing health care and public health services to American Indians and Native Alaskans at the Indian Health Service, as well as to incarcerated individuals within the Federal Bureau of Prisons. They provide food inspections at the National Park Service. They respond to natural disasters with the Administration for Strategic Preparedness and Response, or ASPA. They care for veterans at VA clinics across the nation, provide health care to the United States Coast Guard, and so much more. Our public health service officers provide essential health care services to underserved and vulnerable populations. They respond to public health emergencies, even global emergencies, and they lead public health programs in policy development, in advanced innovation in science and in public health science. Now, the origin and history of the United States Public Health Service traces back to July 16th, 1798, when Congress passed an act signed by President John Adams creating the United States Marine Hospital Service to protect against the spread of disease from sailors returning from overseas ports, and thus the Public Health Service was born. And serving as an admiral in the United States Public Health Service Commission Corps was one of the greatest honors of my career and one of the greatest honors of my life. So I'd like you to think about joining the United States Public Health Service Commission Corps. We have many, many officers that have master's degrees in public health and doctorates in public health. And it is a terrific opportunity to serve your nation and advance public health in our nation and the world. Now, in my role as the Assistant Secretary for Health during the administration, I oversaw a number of program offices, including our Office on Women's Health, the Office of Minority Health, the Office of Infectious Disease, HIV/AIDS Policy, the Office of Disease Prevention, Health Promotion, and the now discontinued Office of Climate Change and Health Equity, and more. Each day, we work to address the diverse public health needs of everyone living in our nation. We led key HHS policy initiatives to advance public health and health equity was fundamental to all of our work at HHS. Among other priorities, we focused on reproductive health care, LGBTQI+ health equity, the health impacts of climate change and health equity, ending the HIV epidemic, responding to the syphilis crisis, food and nutrition security and food as medicine programs, and prioritizing long COVID research and practice. And so I mentioned health equity. Achieving health equity requires valuing everyone equally. And in the Biden-Harris administration, we did this through focused and ongoing efforts to end avoidable inequalities, to address the health impacts of historical and contemporary injustices with considerations of the social determinants of health and health disparities. And I firmly believe that we have not made true progress unless we have all made progress. I want to highlight a moment the significant strides we made in advancing LGBTQIA+ health equity. In the Biden administration, HHS finalized protections from healthcare discrimination for LGBTQI+ Americans, designated LGBTQIA+ and HIV-positive older adults as populations of greatest need, safeguarded youth in the foster care system and the runaway and homeless youth system from the harms of conversion therapy, prioritized data equity with the HHS Sexual Orientation and Gender Identity Data Action Plan. We safeguarded the nation's blood supply by removing outdated blood donation standards that prevented gay and bisexual men from being blood donors, replacing those outdated standards with a new guidance where all blood and all plasma donors are asked exactly the same questions. And we finalized the first ever report on the health needs of intersex Americans. Now, my training in medical school and in pediatrics gave me a very specific but a very clinical approach to individuals with intersex conditions. But, taking more patient-centered care requires us to listen to our patients and to listen to intersex people. And intersex people are asking their clinicians to listen to them, to hear their histories of medical mistrust, their fear of going to a doctor, even for routine preventative care. So we really need to critically examine current models of care to ensure that bodily autonomy and informed consent are central to the care that we provide to intersex people, and of course, really for all people. These efforts are all under siege by the current administration. Thus, I want to acknowledge that this is a very difficult time for LGBTQIA+ health and for the health needs of trans youth and their families in particular. The political and ideological attacks against our rainbow family are not grounded in science or evidence. Let me be specific. Gender-affirming care is essential health care. Gender-affirming care is mental health care. Gender-affirming care is quite literally suicide prevention care. It improves the quality of life, and it literally saves lives. It is based upon decades of study and is an evidence-based standard of care medical treatment. In public health, we need to stand up for the scientific process that leads to the development of standards of care, which, of course, evolve and change over time. And they have for transgender medicine no differently than they have for the treatment of type 2 diabetes over the last 10 and 15 years. Based upon this long history of research and medical evidence, the overwhelming majority of professional medical organizations still endorse transgender medical care, gender-affirming care where it is medically necessary, safe, and effective for transgender and non-binary youth and adults. Those who attack our LGBTQIA+ community are driven by an agenda that has nothing to do with science and nothing to do with medicine. And I feel that we all need to take a stand on behalf of those who are being hurt by those attacks. Now, if someone needs a friend or an ally or simply a supportive individual to advocate them, everyone in this audience has the power to do that. In fact, research from the Trevor Project shows that LGBTQ youth experience significantly lower levels of suicide attempts when they have one supportive adult in their life. Then that might be a parent or a relative, but it might not. It might be a teacher. It might be a coach. It might be with their faith leader. It might be you. Sometimes all it takes to save a life is one supportive adult. Now, on the macro level, public health can continue to advance data equity based on sexual orientation and gender identity and can continue to prioritize health disparity prevention, analysis, and response. This isn't woke, it's public health. Data equity, including SOGI data, is precision public health. It's how we put resources where they are needed most. And health disparity work is population health. It's how we keep the whole society safe from viruses and other communicable diseases and other illnesses. I started my medical residency in pediatrics in Mount Sinai Hospital in New York City in 1983. I was 13 when I did that. No. At the very start of the HIV epidemic, I watched patients who were children at that time, infants and other children, adolescents, all pass away. Some of their mothers died. Some of their fathers died. I saw teens in adolescent medicine who died, as well as friends and colleagues. It was terrible because the science we have today in terms of understanding HIV, diagnosing HIV, and then treating HIV with antiretroviral therapy, ART, and the concept that U equals U, that undetectable equals untransmittable, didn't exist. PrEP, or pre-exposure prophylaxis, didn't exist. Post-exposure prophylaxis didn't exist. So I was there at the beginning of the HIV epidemic, and I want to be there at the end of the HIV epidemic. You can applaud to that one. In the Biden-Harris administration, we made incredible strides, including the FDA approval of the first ever injectable form of HIV PrEP, the U.S. Preventative Service Task Force issuing a grade A recommendation for all forms of HIV PrEP, calling them safe and highly effective for preventing HIV. The CMS issued a national coverage determination that made all forms of PrEP free for anyone on Medicare. And of course, other forms of insurance tend to follow Medicare. My office created a campaign called I Am a Work of Art, ART, to promote adherence to antiretroviral therapy. And we addressed a key social determinant of health when the Ryan White program ended their long-standing prohibition on using their funds to pay for security deposits. Because if we can't get people into housing, we're not going to get them to stay on their medications. I also had the honor of leading our nation's syphilis response. And I have to tell you, when I went to medical school all those years ago, and I was thinking of my career and what I might do, I never knew that I would be essentially the syphilis czar of the United States. Who knew? Or czarina, as it might be. But we formed an interagency task force to rein in syphilis and congenital syphilis. We reversed a nationwide shortage of long-acting bicillin, which is the primary treatment for syphilis, and the only treatment that's approved for people during pregnancy. We advanced access to doxycycline for post-exposure prophylaxis, or DoxyPEP, with the first ever CDC clinical guidelines on DoxyPEP for STI prevention, and we implemented these guidelines to ensure DoxyPEP access, for example, at the Indian Health Service and their Ryan White clinics. We worked with SAMHSA's harm reduction grantees and Title X family planning clinics to implement DoxyPEP. And we published clinical considerations to help providers understand when to use the new rapid tests for syphilis. Now, syphilis, of course, fundamentally is a health equity issue, because a disproportionate burden of disease impacts communities of color, including Black and brown communities, as well as American Indian Alaska Native communities. And we work to ensure that prevention resources went to the areas at greater risk. In other words, those in Vermont did not have as much of a risk as those in Georgia. So we set up 14 priority jurisdictions. We monitored the situation continuously to direct resources where they were needed most. So that is health equity work in real life. And through the work of the National Syphilis and Congenital Syphilis Task Force, we did just start to turn syphilis around, but we need to continue to be vigilant and continue all of that work. Constant vigilance, as from Harry Potter. I also want to speak about climate change and health equity. One of the pressing threats that we face every day is the health impacts of climate change, which pose a significant risk to the health of people in the United States and throughout the world. Climate change continues to exacerbate severe weather events such as extreme heat, flooding and wildfires, and worsens physical and mental health stressors such as poverty, chronic stress, and asthma. And we have seen those impacts of fires and smoke inhalation in Los Angeles, of challenges of mold from repeated flooding in Vermont, and extreme heat on health of farm workers. I was in Orlando, Florida, speaking with migrant farm workers, and they talked about in their communities that they leave their kidneys in the fields. They leave their kidneys in the fields with severe rates, high rates of renal damage and renal insufficiency in young people in their 20s and 30s because of the impacts of dehydration in their farm work. Unfortunately, the communities most impacted by climate change are often those that face economic and social marginalization, which makes it even more difficult for them to prepare for, respond to, and recover from the hazards associated with climate change. This includes, of course, communities of color, indigenous populations, those with low income, seniors, children, rural communities, and people with limited access to health care and those with underlying health conditions. Historically, these communities have struggled with greater exposure to extreme heat and pollution, exposure to and lack of preparedness for extreme weather events, and other environmental injustices such as decreased access to clean air, safe drinking water, nutritious food, and safe shelter. What's more, the impact of these adverse weather events due to climate change puts a strain on our healthcare infrastructure. And communities across our nation need to know that health systems that they rely on, from hospitals to pharmacies to rural clinics, need to be more resilient to the impacts of climate change. I saw this in the communities in northern Vermont after the third round of flooding in a year, and met with healthcare providers who had shared that their home health workers are stranded from accessing roads that they could take to their patients. I also visited Tybee Island in coastal Georgia, which has one road to and from the mainland. They have no hospitals, urgent care clinics, or pharmacies. And in peak season, they have 10,000 people on the island, and the road completely floods out. The road can flood out. So we need to work on these creative strategies for healthcare system resilience, and this must be part of public health's continued focus as our climate continues to change and evolve. In regards to reproductive health, the devastating impact of the Dobbs decision has led to a patchwork of laws throughout our country that confuse and complicate public health. Reproductive health is public health, and the full range of reproductive health care options are necessary, including abortion. Abortion is health care. But reproductive health care is broader than that. It's also sexually transmitted infection prevention care, pregnancy care. It's about cancer prevention and the HPV vaccine. It's about quality family planning services. It's about comprehensive age-appropriate sex education. And it's about access to birth control. One of the victories of public health over the last 30 to 35 years has been the continued decline in the unintended pregnancy rate and the continued decline in the adolescent pregnancy rate due to the availability of these services. These are all threatened. One of the offices that reported to me was the Office of Population Affairs, which oversees the nation's Title X family planning programs. So I was trained in adolescent medicine in the Title X clinic in 1987. I ran a Title X clinic when I first arrived at Penn State College of Medicine in Hershey, Pennsylvania, where I was told that the youth didn't need a Title X clinic in Hershey because young people didn't have sex in Hershey. Who knew? I mean, yeah. We worked to ensure that Title X would cover necessary family planning services regardless of one's ability to pay, so that these clinics could continue to be an important access point and support for the sexual and reproductive health care needs of adolescents. So, at the time I graduated from the Tulane School of Medicine, all those years ago, I never thought that I would be here, that I would have been the Assistant Secretary for Health and a 4-star officer leading the United States Public Health Service Commission Corps. So, every experience, whether it seems big or small, adds valuable life lessons for all of us. And on days that all of you, whether you're students or faculty, you get frustrated with our public health system, and you know, there'll be a few. Not many, but a few. Please remember the ways in which your work improves people's lives and literally saves people's lives. One of the most significant lessons I learned in my training was the importance of teamwork. Whether it was in the hospital or the clinic or in public health, you have to work as a team to take care of these complex issues, complex patients, or complex public health issues. Collaboration and communication are far more valuable than competition. So my recommendations to all of you are to plan big and think big. Have big goals for your careers. And know that life may take you on many different turns and send you on many different unexpected paths. But please, continue to work for the common good. As I have said before, we have not made progress unless we have all made progress, and we all have a role to play in making that happen. Now, I'm a positive and optimistic person, and I'm positive and optimistic because I choose to be positive and optimistic. Pessimism and despair doesn't help motivate us or others to do our work. And looking around the room at all of you actually fuels my positivity and my optimism and my hope. Your actions as students and faculty have the power to help shape a better, more inclusive world for all of us. We often do not realize the impact that we have on the world around us through actions both big and small. So in conclusion, the challenges of the recent years have reminded us of a fundamental truth, that we need each other, that our happiness and our very survival depend upon our connections to one another and to our community. And that spirit of community is what we need now more than ever. There are many groups that face unique and increased risks from multiple health challenges, but I continue to have hope for the future. As the Reverend Martin Luther King Jr. reminded us, we shall overcome, because the arc of the moral universe is long, but it bends towards justice. So I am hopeful and optimistic about the future of public health, and I am so glad that all of you will be a part of it, because you all are our future. And as a trusted voice in your community and frontline professional, you have the power to understand, to educate, and respond to your community's needs. Because we can do better. We must do better. And with your help, we will do better. Thank you very much.
So this part of the program will just delve a bit deeper, I want to first start out by giving another round of applause for those incredible remarks. So I'll ask a set of questions. I'd like to thank those of you in the audience who submitted questions at time of registration. A lot of those are built in. There will also be a QR code maybe that's it. If not, the team will put it up. We will have a little time at the end to have some live Q&A from you. So if you just capture that QR code, send it, the team will get it to me, and we'll hopefully get as many questions as we can answered. So I want to start off at the beginning. Sometimes I like to ask about the call, but you kind of addressed that in terms of the invitation to serve under the Biden administration. But I want to start still with our students in mind. And one of the key benefits of having a program like this and other programs that we do is our students get exposure to tremendous leaders like yourself, and to be able to have a lens and insight into impactful and influential work at the highest level. And so to start there, can you share more about what it means to be Assistant Secretary for Health, and what were some of the things that you focused on in your job?
Sure, thank you. Well, it meant the world to me to have this position. It really was an amazing, unique opportunity to help people. You know, really, in my medical career and in my public health career, I have felt very gratified by that, because all I tried to do, and all you're all trying to do now and in the future, is to help people, right? And so public health does that with, you do that in medicine, you might do it patient by patient, or developing programs or teaching. But in public health, you are able to do this with this broad brush, you know, first for me in Pennsylvania, and then nationally. And so it was a unique opportunity to do that. So, you know, we focused on health equity. Health equity, as I mentioned, was fundamental. It was foundational to all of our work. And that started with our secretary, Secretary Javier Becerra. And he gave us those marching orders for every different division at HHS. And so our work, I mean, I really divide the work that I had as Assistant Secretary into three different categories. One was the Public Health Service Commission Corps, as I mentioned, leading those fantastic officers who do medical and public health work throughout our nation. The other was leading the offices, and many of which I mentioned. And so we focused on reproductive health care and Title X programs and the syphilis crisis. We focused on food and nutrition security and food as medicine. We focused on long COVID and formed an Office of Long COVID Research and Practice. I focused on LGBTQI+ health equity. We focused on the environmental work and the climate change work. So that's just ending the HIV epidemic and more. So all of the work through those offices. And the third line of work is more subjective. So as a staff division of the Secretary's office. So my office was a staff division as opposed to an operating division, which are a little bit more siloed, CDC, FDA, NIH, et cetera. So I'm an arm of the Secretary. So he would call upon us to pull together different strands throughout HHS or even the government to work on specific issues. For example, long COVID, the climate change work, the syphilis work, but also sickle cell work, the nutrition work, and more. Often with no people and little money. And so they congratulated me over and over again for doing, fulfilling all of the missions that we had to do with no people and no money. So I guess it was a compliment. Eventually I was hoping it would lead to, I could do a lot more if I actually had some more people and some money, but not to be. So they called us the connective tissue of the department. I was personally hoping for the beating heart of the department, but I got connective tissue, so that's okay. So those were my three line of efforts as the Assistant Secretary for Health.
Terrific. So I'll ask a follow-up question that also kind of keeps our students in mind, but or even earlier professionals, but one of the remarkable things as I listen to your remarks and think about your career journey is that you've had success at multiple levels. And in part because of that success, new opportunity, right, and your openness to be able to step out of your comfort zone to embrace that new opportunity. And so I just would like to invite you comment on that, as our students are, much of their careers ahead of them and will find themselves perhaps in similar situations.
Absolutely. I have always enjoyed and embraced change and transitions. And so I have really embraced having a steep learning curve and kicking myself out of my comfort zone. So whether that is, going from New York, from 80th and First in Manhattan to rural central Pennsylvania, whether that is going from public in medicine and in academic medicine to public service and public health, from going from Pennsylvania nationally, taking on the uniform of the United States Public Health Service Commission Corps. For the Assistant Secretary, that's a choice. Surgeon General is always in uniform, but for me it was a choice, and I really wanted to do that. And I was mentioning to you all that was really one of the most meaningful aspects of my position. So I think it is very important for people to work to do that, to embrace change and to embrace opportunities to step out of your comfort zone and to do something new. And one example I will use, probably one of the times I really felt out of my comfort zone, making note of the weather, your lovely weather here today, was we went to Alaska. And we went to Anchorage, which is, a small city, but then we left Anchorage and we went to Nome. We went to the village of Savunga on Civic Island. We went to Kitsibu and Kuyana, and then up to Utqiagvik, which is the top of the world. And I was very much out of my comfort zone. The environment, the challenging living conditions, it was an amazing trip. But I always have relished that opportunity, and I would encourage you to do that. I mean, you might think you know where your career is going, but I did. If I was in academic medicine at Penn State, I know Penn State's a little controversial here, but anyway, I was at Penn State, and doing all my missions, right? So I saw patients, I was teaching, I was doing clinical research, I was doing administration, and despite everyone recommending that I not leave to become the Physician General of Pennsylvania, I just felt it was a unique opportunity, and I jumped. And so, as my mother said, it led to something.
Terrific. So in recent years, Washington has been an especially partisan political environment, and imagine that you had to work with people who didn't necessarily share the same perspectives as you. And so I want to just inquire about what some of the strategies that you use in trying to help work across various lines of difference.
So, things have gotten much more partisan, even from when I came. When I was in Pennsylvania, as I mentioned, I was unanimously confirmed twice and almost unanimously a third time. And I worked very closely with the Republican-led legislature in Pennsylvania on public health issues. And then we might not always agree on everything, but we could agree on a lot, and we did. I think that politics particularly started to become very prominent in public health during the acute phase of the COVID-19 pandemic. You saw that here in Michigan. In fact, the protests at the State House here in Michigan were some of the first public protests against COVID-19 mitigation efforts. And I think that has led to a real split in public health from a partisan political nature, and is carrying through even today. So, but I had a number of opportunities to meet with legislators of the other party, and to me, people would say, "How does it feel to be a politician?" I've never been a politician. I've never really considered myself to be a politician. Now, I understand that the positions I were in are political nominated positions, but I've always considered myself a physician and public health leader. And in my opinion, that shouldn't be political at all, but unfortunately it is. And so I think it is incumbent upon all of us to work across the aisle, to work across parties. None of the public health work we're talking about really in its heart is political at all.
Prior to joining the Biden administration, you served, as you mentioned, as Secretary of Health and Physician General in Pennsylvania. And how did working on public health at a state level differ from that at a federal level?
Right. So it's interesting, and you might not I mean, people might not know this, but there's a certain bureaucracy to the federal government. Did you ever hear that? So, there is a certain bureaucracy in Pennsylvania as well, but that's kind of like the minor leagues, and then you go to the majors in the federal government. You go to the show, as they say, and so you have to work through that. And I had a great staff that would cut through, either bureaucracy at HHS or throughout the federal government, and we worked to get a lot done and trying to work past that. To be honest with you, I did not find the public health issues that different from Pennsylvania to nationally. It's just that I had to pull back my scope of, instead of just looking at Pennsylvania's numbers or the Mid-Atlantic numbers, but to like for COVID or something, but to look across the whole country. Whether we're looking at COVID-19 rates or vaccination rates, about overdose rates, about nutrition, about HIV, or any of the issues that we were dealing with. I think I had mentioned that one of the biggest differences, though, was my commission and taking the uniform of the Public Health Service Commission Corps. That was something that, again, kicking myself out of my comfort zone, that I've never experienced before, and it turned out to be one of the greatest honors that I had in the federal government.
Terrific. So I want to move in to sort of a next segment in terms of questions, really centering this issue of health equity.
Sure.
And work just to ensure that everyone has an optimal level of health. And in the lead up to the presidential election last year, we saw, in my view, just a disturbing amount of negative ad campaigns, particularly in battleground states like Michigan, I imagine Pennsylvania as well. And some of these included ads that had specific anti-trans rhetoric.
Yeah.
And in recent years, we've also seen a growing number of states that have imposed restrictions on gender-affirming care for young people. And so, I'm would like to invite your thoughts.
Sure.
What message would you deliver to the public in response to some of these emerging constraints on and targeted activities
Sure.
in terms of healthcare?
So, the ads were very difficult and very challenging, and many of them, or most of them, contained my face in those ads. So I have to tell you, I knew that my appointment would be controversial. I did not expect to be literally the tip of the spear of the culture wars of America, and it was challenging. But I've said in other interviews, I'm fine. I'm a pretty strong and resilient person, and I'm really fine. What I worry about is the impact of those ads on other people in the community and their families and their providers, and the challenges, particularly for young people and their families, to that rhetoric and that vitriol. I think it is important to note that the laws that have passed in many states of the country targeting transgender medicine and targeting transgender people in general are a response to a specific iterative strategy from conservative think tanks in Washington to target our community in order to split the broader LGBTQIA+ community and to split the progressive community. And unfortunately, they were very successful. But I mean, many of the laws that passed come out of a specific cookbook. I mean, often the people who were even introducing the laws didn't even know what they were quite introducing. They were handed a playbook and they followed their playbook. And it was unfortunately tremendously effective, starting with trans athletes, then going on to transgender medicine for young people, and then transgender medicine and trans people in general, which is where we are now. And then, it wouldn't surprise me if they go on to the broader LGBT community as well. So, as I was mentioning before, transgender medicine is an evidence-based standard of care treatment. And we have a lot of research that was going on in the United States, other countries. A lot of it's being curtailed right now. And it evolves over time, as do the medical standards of care for any medical treatment. Should it be better? Should there be more research? Yes. Can it get better? Yes, as treatment for diabetes has changed a lot in the last, tremendously actually, for type 2 diabetes in the last 10, 15 years, especially now with GLP-1 medications, et cetera. So a tremendous change. And so there's been change in the care, standards of care for young people as well. Most of that care is done at children's hospitals throughout the United States. And so I would ask the question, if you have a child with diabetes, you would probably go to the Children's Hospital in your city. So here, you'd probably go to Michigan's Children's Hospital. If you have a child with potentially an eating disorder, you would go to the adolescent division in the eating disorder program at the Children's Hospital. If you have a child with depression or anxiety, you would probably see the child psychologist or child psychiatrist at the Children's Hospital. If you had any medical condition, you'd go to that clinic. So if you have a child with gender issues, why are we involved with the state legislature? You would go to the gender specialist team at the Children's Hospital. I even had agreement with the AMA on this and spoke with Jesse Ehrenfeld, who was previous president of the AMA, at a conference for PFLAG, for families of LGBTQI plus youth, is that you're really getting in between a physician and a team and a medical provider and a young person and their parents, because all this is with parental consent. And so why are states prohibiting that treatment? They're not impacting the treatment for diabetes or other things. So I view it in that lens. Now, it is very much of a challenge in over half the country, where gender-affirming care or transgender medical services are not available to young people, and they're trying to make that across the country. Now you have people like your Attorney General and governors trying to stand up for that, and we'll see how things come out in the courts, and we'll see how things are. But it is very challenging right now for those young people, for their families who are just trying to parent their child, their teenager, and for their medical providers who have been threatened. So we're going to have to stand together, and again, I'm going to, in the face of all that, I choose to remain positive and optimistic, but I'm extremely realistic and understand the challenges that we have now.
Terrific. So you mentioned stand together. You're talking to an audience who believes in attainment of health for all, and so for those who want to take proactive measures, what are some of the ways to combat the trends that you just discussed, and including health care for trans individuals?
Well, I think it's important for public health professionals and medical professionals that all of us do stand together and continue to support health equity, which I've said before is fundamental to public health. This is not a new concept. Health equity in public health is not a brand new concept. And addressing the social determinants of health is not a new concept. And so I think that we need to stand together in that. I think that we need to, as I mentioned, in the LGBTQI plus community, to stand together as a rainbow family, and we need the help of our allies to stand together, because we are all stronger together. I think it's important not to have an emotional reaction, if possible, to the challenges that we're facing. And I know that's difficult. But I have often, in my clinical training, learned to compartmentalize my emotional feelings when I need to do my work. So if I'm a pediatrician and this critically ill child or a teenager arrives in the emergency department, that can be extremely emotional, the parents, et cetera. Well, you can't let your emotions carry you away, right? You need to put it someplace and then do the work that you've been trained to do as a physician or as a nurse or as a social worker or anything else. Well, we need to do that in public health as well, is be able to compartmentalize our emotions. Now, you have to bring them out later with your friends and your family, however you process stress, but we need to do our work now. So I think that we need to do that. And I think we need to not make anticipatory changes. That I don't think it is wise to make changes in anticipation upon what others might do or say, because we don't know exactly what they're going to do or say. And there are what's the right word? Blocks to that. There are safeguards. The Congress can be a safeguard. The courts can be a safeguard. You have governors and others in different states that can be a safeguard. So we do have safeguards and checks and balances in place. So I think it's important not to make anticipatory changes based upon tweets and rhetoric. That, you know, if a change has to be made legally, then I'm always recommending that we follow the law. But in often cases, we're not there yet. We've just heard pronouncements that don't have legal weight. So we should not over-anticipate and jump the gun and make changes that could hurt people or our communities in anticipation of what might happen in the future.
Terrific. So we received several questions at registration asking about some of the recent federal executive orders that you didn't name, but one of the things that I think are implied by your comments. And some of our attendees were wondering, as we've also seen pressure put on certain agencies, how do we make sure that health agencies can communicate with the public and share evidence-based information?
Sure. Well, remember, I mean, there are three levels of government that we all have. I mean, there's local government and local health departments, and there's state government and state health departments, and then of course we have the federal government and our federal health department. So, I mean, I think that state and local health departments need to continue to do their work. And I know many of them, and they will continue to do their work. And, you know, dealing with these political challenges is not new for my colleagues in many other states, in many red states. I mean, they're used to many of these challenges for the state in their health departments for Georgia and Alabama and Mississippi and Texas and Florida, et cetera. And so there are ways to work through that. And so I think that we need to learn from them and listen to them, whether they are in state or local health departments in other parts of the country, and to learn, well, how did they still do good public health in a challenging environment, or an environment where health equity is controversial. And so I think we can learn a lot from them. And I unlike some of the rhetoric that I've heard, I have to tell you that our civil servants in public health at the local, the state, and the federal level are absolutely dedicated public health professionals. And I think that they're going to do their work and continue their work as much as they possibly can. And I have faith in them.
Terrific. Just a reminder, you are able to submit questions, and let you know how good you are. We got a question about anticipatory compliance, and you've already addressed it, so without being prompted.
I anticipated that.
But you're welcome to continue to include questions. So another question that we had at time of registration just inquires about how women's care might be impacted. Are there things that we can do at a state level just to help ensure that women have access to reproductive care that they need?
Absolutely. So as I mentioned, the Office of Population Affairs was under my purview, and the Title X program was under my purview, as well as the preventing teen pregnancy, teenage pregnancy prevention program, and the small but mighty Office of Adolescent Health. The Title X program, access to knowledge about reproductive rights and access to birth control, comprehensive sex education has been a victory in public health. I mean, the unintended pregnancy rate and the teenage pregnancy rate has consistently gone down since the 80s. It's remarkable. So we don't want to lose that progress. And so I think that it's going to be to the states to be able to do that. In addition, is the right to abortion. And abortion is health care. It's a reproductive. It's essential part of the toolbox for reproductive health care for women. And I think that the states have a absolutely critically active role in terms of providing that care to people who live in your state, but then also to people who travel to your state. And that's what's happening, is that women and families are coming to Michigan, they're coming to Illinois, they're coming to Maryland, they're coming to Colorado and New Mexico and California from other states to get the health care that they need and that they deserve. And so I think that Michigan and other states are a bulwark for reproductive health care for women. But there are concerns about other reproductive health care, including even the right to contraception. I mean, in the opinion from the Dobbs decision, the contributory opinion by one of the justices, there was even an allusion to Griswold versus Connecticut, which is the contraception law, which is from I believe that case was from the 60s, and threatening that law. So I think that it's important for us to be vigilant and to continue to advocate for the full range of reproductive health care for women and families.
Terrific. I want to follow up on your comment. And as things vary across states, that also potentially introduces some challenges along the lines of health equity. And, for some people who may have access to be able to cross state lines to seek care versus those who are not in a position to do so. So I'd like to just invite your comments about that as well.
So the ability to seek care out of state is a health equity issue, because not everyone can afford to travel out of state. Now, if you're in North or South Dakota, you might be able to go into Wisconsin. But if you're in Georgia, where are you going to go? If you're in Florida, so you're going to really have to drive a long way, or you're going to have to fly. And not everyone can afford to do that. And so it is really, it results in only people of means can actually get the health care that they need and deserve. And that is true now for transgender medical care. So I think that's an enormous health equity issue that we should continue to work on. I don't see a quick solution right now, but I'm still optimistic for the future.
Great.
So we have created, the term I used when I was the ASH, Assistant Secretary for Health, was medical refugees. We have created medical refugees in the United States who have to leave their state to get the medical care that they need and they deserve. I think that's a shame. In the United States of America, we have medical refugees. And I think that's going to get worse, and then it'll get better.
So I want to switch gears a bit and talk about the issue of misinformation. And, we're seeing this a lot in public health, but not focused on public health. Certainly during the campaign season, you saw lots of misinformation, as I alluded to earlier. And I'm just wondering, during your time as Assistant Secretary, I'm assuming that you've acquired a lot of experience dealing with information, and what are some of the most effective ways that you think in the field of public health that we can work to combat misperceptions and to try to promote accurate information?
We saw the impacts of misinformation and overt disinformation even before the acute phase of the COVID-19 pandemic and before I was in federal public health, and particularly about vaccinations. Now, the root of this comes from one of our own. The root of this comes from the infamous Dr. Wakefield in England, who wrote an article in the early 90s stating that the measles vaccine had a relationship to the development of autism. Now, what it's turned out is that he fabricated that data, and it was a spurious article, and it's since been withdrawn by The Lancet. It has since had numerous studies which has proven, even, I know you work with big data and other people do epidemiology. I mean, from clinical trials to big data sets has been proven not to be true. But that has continued. And vaccine reluctance and vaccine hesitancy is really, it's actually not partisan. It's somewhere where the far left and the far right meet in Oz, and has been a challenge. And we had even before the pandemic, and even before certain advocates have gained prominence, and so we had no cases of measles in the United States in the year 2000. We also had very little cases of syphilis in the United States, but we had no cases of measles. And now we not infrequently see measles outbreaks, including right now one in, is it Texas? In Texas. And that's because of that misinformation and disinformation. So I think it is incumbent upon us, now it's even worse, that it is incumbent upon us in public health at all levels, whether you're local, state, federal, or in academics, to counter that misinformation and disinformation with facts, not alternative facts, actually facts, and to continue to talk about the scientific facts that we know. Now, how we do that, I think, needs to continue to evolve. And I think that the field of public health communications needs to continue to evolve and to get better to be able to counteract that misinformation and disinformation. So a question that I've been asked a lot in the last day or so has been about social media and how to do that with social media. Well, you are talking to an out and proud baby boomer. And I don't know the answer to that question. You know, I am not on social media. And I don't know the ins and outs of social media actually that well. And so I will look to you all. You know, people who in public health, but people in communications, I mean, who study social media. I know in adolescent medicine there are some specific people who study the impact of social media on adolescents. I will look to young people, by which I mean anybody younger than me. If you're not in your 60s, you're a young person. About how best to use social media. I don't know. But it isn't impossible. I mean, we just need to study it better and to learn from it, like we learn about everything else. What are the threads to pull? That was a little bit of a pun with threads. What are the threads to pull to be able to do that? I don't know, but we should be able to figure that out.
I take that as an assignment to some of the students in the room.
Absolutely. Absolutely.
So picking up, you mentioned the lingering vaccine hesitancy and how some of that is spurred by misinformation. There are instances, though, where there's been mistreatment, even by the medical community in the past. Instances that we're seeing now, as I think about communities of color in the past, anti-trans rhetoric now by way of the federal government. And so I want to really nail in on the importance of trust. Like at some point as we move forward as a public health or medical community really trying to support healthcare needs, we will be left with that harm or breakdown in trust. And so I would like to just have you invite you to comment.
Well, trust is absolutely critical in medicine, and it's absolutely critical in public health. And so as a physician or other medical provider or mental health provider, you need to have this trust within the doctor-patient or doctor-client relationship. And I think it's critical in public health as well. And I think, prior to the last 5 years or more, I think the public did have more trust in state and particularly federal public health, CDC, NIH, FDA, et cetera. I think that has been severely damaged, particularly by the politicalization of the acute phase of the COVID-19 pandemic. And so I think trust has to be earned, and I think that it'll be incumbent upon us now or certainly in the future to earn back that trust. But this is not the first time we've had problems of trust, and you allude to human research that broke that bonds of trust with the Tuskegee experiment, with other challenges. Particularly, I'm thinking of sterilizations that were done in the Indian Health Service in the 60s and things like that. I mean, so many ways that medicine and public health broke the trust of people, particularly communities of color, but not exclusively. And I think that we have to earn that back. I think we have to acknowledge it. I think we have to apologize for it. And I think that we have to then do better. And trust has to be earned, and it's our responsibility to earn back that trust.
Absolutely. So we have time for one final question, and a lucky audience member, actually at time of registration, gets it. What would you say to an aspiring transgender leader who wants to run for the U.S. House of Representatives in this political climate?
Well, I would say I would follow the path of Sarah McBride. So Sarah McBride, who I know well, has been elected to the House of Representatives as the representative from Delaware. And I saw her last week in Washington. And she's responding with grace under severe pressure. a very, very tense, challenging environment. And she is responding with such leadership and grace that she's the future. And so I would encourage you to continue to do that, to work on a political career, and public health and medical professionals can certainly go into politics. I mean, I don't think that I went into politics, but I've never been elected to anything. But I think that that would be a very valid political career, and I think it can be done. Now, I probably wouldn't go to Texas to get elected, and I think. But if you're here in Michigan, or you're in Massachusetts or California, or obviously Delaware, or certain parts of Pennsylvania and certain other areas in our country, in Colorado, and then I absolutely think that you could get elected to local, statewide, and even federal public office. And young people are our future, and I think that that we need to not respond to the current environment with fear. I think that we need to get past our fear, and to do the right thing. What I'd often tell my staff, both in Pennsylvania and here, is that when in doubt, we need to do the right thing. Now, you got to figure out what the right thing is, and that's not easy all the time. But when you do, don't be afraid to do the right thing and continue to work for the common good.
Terrific. So I want to, in closing, thank you for your expertise and the diligence that you take to your work. Thank you for choosing a path to serve the public. And then thank you for your courage. Will you please join me in thanking Dr. Levine? Terrific. And for those of you who will be staying with us, it is time for a break, but just to remind you that there will be a reception starting at 2:30. Look forward to talking to many of you then. Thank you.
We're going to go ahead and get started, everyone. All right. Good afternoon, everyone. Thank you all again for being here today. We had a wonderful session just a short while ago, and I'm looking forward to opening this next session, in which we have a very exciting panel ahead of us. I want to start by saying what an important and critical time it is for doing the work of building health equity. My name is Enrique Neblett, and I'm honored to co-lead the Ideas Building Health Equity Initiative here at the University of Michigan School of Public Health, alongside Justin Colosino. Our initiative was launched, as some of you may know, in December 2023, with the goal of addressing systemic inequities and advancing health equity through collaboration, research, and action. And as you'll see here, at its core, Ideas Building Health Equity, at its inception, aimed to bring together experts across a range of disciplines and build on existing collaborations to identify proven and sustainable ways to dismantle racism and other forms of inequality embedded in society and promote health equity across populations. Since our launch, we've engaged with both university and community partners in a number of meaningful ways. So we started out that December with a kickoff event fostering discussions on health equity and research, which led to the identification of key health equity priorities. And you can see some of those priorities here. These were clusters that were identified across our campus, actually, by faculty, staff, and our community with regard to things folks saw as important. We did this in collaboration with OVPR, and you see some of the priorities here. So populations and spaces where disparities arise, social determinants of health came up, Stress and mental health was a big priority cluster, healthcare services, and policy intervention, cross-cutting themes. Since the kickoff event, we've been in conversation with leaders in the city of Detroit to talk about what are some of the priorities that they see as health concerns in the city in order to deepen and understand health equity needs and concerns. As some of you know, we've been around to a number of faculty meetings to hear what folks are doing. And we've enjoyed learning from you about some of the work that's going on in this area of health equity and thinking about points of synergy as we move forward. And here we are today hosting the exchange, which, as you've seen, is really thinking about how we continue this work. These engagements are shaping our efforts as we work toward long-term impact. And as you can already see, some of the priorities that we identified in December are serving as guiding principles in our work. We started out with a couple of big picture ideas, building a health equity landscape, figuring out what are some high value RFAs that we could take part in, and we really wanted to be able to support proposal development, building teams, as we collaborated with some of the other ideas teams here at the School of Public Health. So we've got four sort of big picture objectives, building on the ones I just mentioned, understanding the landscape, engaging with community partners in doing this work, building the teams to be able to do this work, and then lastly, as I have not mentioned, kind of providing training and capacity building opportunities to do this work as well. One of the first things we did as part of our first objective was we took all of the, well, not all of it, but data from recent digital measures data submitted by faculty with regard to grants awarded to the School of Public Health, as well as all of the publications last 5 years or so. And this is the word cloud that resulted from doing that. So if you take a moment, you can see some of the prominent themes in the work that's being done at the School of Public Health. As you work your eyes through it, cancer, risk, COVID-19, women, pandemic, exposures, disease, environmental, community, genetic intervention, data, and Michigan, of course, are some of the work that are most prominent and that reflect the breadth and depth of health equity work across our institution. We're in the process now of engaging in more rigorous and formal analysis with a biostatistics student to build on this sort of preliminary look at what some of our areas of expertise are. Another thing that we did in this work early on was to try to identify points of synergy between the areas of expertise in the School of Public Health with community interests as well. So the Detroit Community Academic Urban Research Center has a social networking event each year in which we bring together folks from Michigan, community members in Detroit, and Justin actually took a look at from this sort of Excel sheet that folks fill out in terms of their interests, what were the points of synergy? And these were the 5 areas that came up when we did that first exercise. A couple months later, we extended this to think about what are specific concerns in the city of Detroit. We asked community leaders who are part of the Detroit URC board, what are the things that are most pressing in Detroit right now? And we wanted to see how those things mapped onto our areas of expertise. And you can see some of the things that came up here. So community members mentioned colorectal cancer, early onset and disparities in care. These are sort of the top 5, which maps onto what we saw in the word cloud as an area of expertise. Community members mentioned air pollution, trucking, and asthma, which also exposures were another sort of keyword in the cloud. Mental health and post-COVID challenges, and particularly concerns about access to mental health resources was an area that folks raised concerns about That's also one of our areas of expertise. And then 2 more areas here that you see, chronic disease, so community residents reference the lack of access and relation to early detection, particularly with regard to diabetes, which was another larger word in the cloud, and care among the Michigan research topics. Community members highlighted how important they felt the role of researchers was to be able to play a key role in translating the expertise here at the university into policy advocacy. Okay, let me scroll down here. With colleagues in the School of Public Health, we've explored proposals development focused on AI, machine learning, and health equity, and other topics. But one tangible example of our efforts to build interdisciplinary teams is the P50 Community Engagement and Dissemination Core that you see here, which is a piece of a center proposal focusing on Michigan cancer and environmental health disparities. Justin and I were invited by colleagues Lee Pierce and Dana Dolinoy to put together different pieces of this center proposal. And I'm not, in the interest of time, going to go through all of the boxes here, but I want to highlight under AIM 2, one of the things that we are doing work with the Community Engagement and Dissemination Core that was proposed was capacity building around training early career individuals in how to do this work using community-based participatory research and doing it in a way that's in community with community or in partnership with community. So this is an example. We hope that there will be many more of thinking about ways in which we can build teams to do this work together. Finally, we're committed to fostering the next generation of public health professionals through training opportunities. So in addition to work done by our project coordinator, Sarah Cadis, to identify relevant coursework, we've been looking at some of the strengths and opportunities across programs in our health equity coursework. We recently sponsored an opportunity forthcoming with the Washtenaw County Health Equity Summer Internship, which this summer will provide a hands-on experience in health equity. You'll be seeing announcements about this very soon, focusing on racial justice and community engagement. This internship, among many of the things you see here, is a partnership with Washtenaw County Health Department leaders, supporting many activities, but one including the implementation of racial justice impact assessment tool and assisting with other community dialogues and training initiatives. One of the things we've talked about as we seek to extend beyond or expand our definition of community is going beyond Detroit, going beyond Washtenaw County and the state to think about community more expansively. As we continue to build momentum, our goal is to create a sustainable, action-oriented, community-informed framework that bridges research and practice to advance health equity. And so having provided these highlights and brief overview, I'd like to now turn it over to my colleague, Dr. Justin Colacino, who will moderate our panel discussion. Thank you.
Thanks so much, Enrique, for that outstanding overview of our program and the work that we've been all doing together. So yeah, I'm Justin Colacino, faculty here in Michigan Public Health, and I have the honor of moderating this distinguished panel. And I would like to invite our panelists to please join me on the stage. And so I'm going to briefly introduce our panelists. So closest to me, Dr. Sari Reisner, Associate Professor in the Department of Epidemiology at Michigan Public Health, and is also core faculty in the Center for Social Epidemiology and Population Health. Next to Dr. Reisner is Dr. Daphne Watkins, who's the Letha A. Chadia Collegiate Professor of Social Work, a University Diversity and Social Transformation Professor, and a Professor of Social Work here at the University of Michigan. And then at the end, Mr. Ellie Samet is a prosecuting attorney for Washtenaw County. Thank you so much for joining us. I'll give our panel a hand. So I'm just going to ask each of you to just briefly introduce yourself, talk a little bit about your experience and expertise in the area of gender and health equity, and tell us a little bit about what drew you to this field and what keeps you in this work. Dr. Reisner, maybe you want to start?
Is this on? Yeah, it is on. Okay, great. Well, thank you so much for having me and us and for organizing this event. Really delighted that we're able to engage in dialogue and exchange, appropriate given the title of our series here. My name is Sari Reisner. My pronouns are he and him. I am a transgender population scientist. I was trained as a social and psychiatric epidemiologist. I'm deeply invested in gender diverse health, also in sex and gender-based research methods. So for example, how do we capture gender identity data, sex data, et cetera, and how do we have methods that are responsive to understanding both sex and gender as determinants of health and well-being at the population level. I got to this work, I've always been a little bit obsessed with gender, I guess, but I got into public health kind of by accident. I started writing grants after I graduated from college, and I realized, holy smokes, I'm doing public health, and fell in love with it. So the idea of equity and the way that gender is associated with the patterns and distribution of diseases across populations and also well-being, and specifically, gender and transgender experience. So that's what I have.
Thanks.
Okay,
Watkins.
that's me. Hi, everyone. I'm Daphne Watkins again, and I think you asked, how did we get into this work?
What brought you to this work?
Yeah, great. So for the past 2 decades, I have been doing work with and in service of Black men. And specifically, my work has focused on mental health, expanding definitions of manhood or masculinities in the plural sense, and then, of course, social support. And so, I got into this work because I always tell my students that research is me search. And it was me trying to search for understanding in myself and how I grew up, my relationships with my father, my brother, various Black men in my life. And so, for me, it was really trying to pull the curtain back and understand exactly what is happening at the intersections of race and gender in particular, and what those experiences look like for Black men in the United States. So, thank you.
Thanks so much. Mr. Savitt.
Okay, yeah. So you probably all think that I'm lost here, but they did actually invite me to be on the panel. I had to double check, despite not having a doctor in front of my name. And so I'm not a doctor. Juris Doctor doesn't count. Nobody thinks it does. I'm the prosecuting attorney for Washtenaw County. You might ask, what on earth does that have to do with health and health equity? Well, there's a couple of answers to that, and I'll say a little bit about my personal experience here beyond that. But the truth of the matter is that public health and crime are deeply, deeply interrelated. I'm a prosecutor that does not particularly want to prosecute cases, because once we are prosecuting cases, it means that a crime has already occurred, and we are trying to minimize the damage that has already been done. And access to health and access to health care across demographic groups has been rigorously shown to decrease crime, to increase well-being, and creates a virtuous cycle rather than, frankly, the unvirtuous cycle that we often see by cycling people in and out of jail, trying to get them treatment there, then they come back, then they're homeless, then they go back in jail. It's a much better way of dealing with things when you prevent it at the outset. So, also in addition to that, I have somewhat surprisingly, during my term in office, had opportunities to litigate, or been forced to litigate, actually, around certain issues pertaining to gender, health equity in particular. Most prominent among those was, along with 6 other prosecutors from across the state, we litigated alongside Governor Whitmer to invalidate Michigan's archaic zombie abortion law that was scheduled to go into effect after the Dobbs decision. We have also led coalitions of prosecutors and other government officials on briefs, for example, supporting the expansion of Michigan's Elliott Larson Civil Rights Act to LGBTQ people, in addition to leading a coalition of 81 cities, counties, and local officials from across the country seeking to ensure that decisions around gender-affirming care for young people remain between kids, their families, and their doctors without state interference. So that's some of the work that I've done, but there really is a profound connection between our day-to-day and health equity, so I'm pleased to be here.
Thank you so much. Yeah, so you can see our panel has very diverse expertise, and I thank all of our registrants for providing questions as you are registering. I've done some work to try to coalesce these questions together, and so I'm going to ask the one that we certainly got the most to start. So really, given what we can consider a rapidly changing political landscape, how best can we keep gender equity and health-focused work moving forward? And so people asked about this across multiple different dimensions. Some people were interested in academic work. Some people were thinking about in the context of legislation. Some folks were thinking about really the frontline public health work that many of our trainees and graduates are doing and our community partners are leading. So what are the strategies that we can use to really keep this important work moving forward? That is an open question for the panel.
I can start.
Easy,
Small question to start
Small
with.
question,
Yeah, I mean, I think we're in quite a time right now. Dr. Levine's comments, I was inspired by her saying, that public health requires that we pivot quickly. I think certainly this time is keeping us on our feet. So, for me, when I think about, the lens through which I think about transgender health is thinking about gender more broadly. And so I like to frame it in the sense that, gender is a multidimensional construct. So there's, gender identity, right? A felt sense of who you are and your gender expression, how you do gender roles, So thinking about these multiple dimensions and the ways that we do gender and sort of keeping that at the forefront. I mean, also think that there's like a clear scientific evidence base to be, talking about that gender is a determinant of health. Like that is a factual statement. And I think from a scientific perspective, we can think about the ways that we can now show, as researchers, how gender shapes health, right? So I can totally nerd out for a minute and talk about a directed acyclic graph in epidemiology when we're talking about a DAG and it's a causal path diagram, right? So if you are the executive administration and you say sex and gender are the same thing, then you have sex to your health outcome, right? But if you are all of us who are not, then you understand that sex goes to gender, right? And gender goes to health, right? And that is around, so for example, help-seeking behaviors. We know that trans people have negative experiences in care, a legacy of mistrust due to the way that there's been a medicalization of trans people and bodies, right? So we know that avoidance of care and sort of suboptimal access to care is an issue that's very strong in the community. But we also see that help-seeking differs across all dimensions of gender. So for example, men, if we say on a population on average, have poorer help-seeking behaviors than women, right? So it's not that the sex is the thing that is biologically causing the health behaviors of accessing care or not, right? That is just impossible. It's gender roles, et cetera, et cetera. So I know this group knows this, but I think that we need to kind of make it very simple and think about what, if we miss that pathway, that causal pathway to health, then what are we not seeing scientifically, right? And that is an intervention kind of point and thing that we need to think about. And how we address that gender then will be sort of, I think, this multi-level piece where we have to think about the different levels of influence and how we attend to that. So that's a small thing, but I'll stop there for now, yeah.
No, that's great.
Yeah, so I think the question focused on what we should do, and the first thing that popped in my mind was don't stop. Right? I think keep going. And I'm going to put on my social work professor hat for just a second and think about the importance of organizing and how can we come together to strategize, to come up with, tactics and strategy for how to proceed forward. I think sometimes our knee-jerk reaction is to react, to sort of jump out there instead of really pulling back for a second and thinking, okay, what tools do I have at my disposal? making sure that I'm going about it in a safe way? And in what ways can I think about the long term, right? Because this is a long game. I just want to also speak to the students in the room for a second. We need you on the other side. And so it's very important to think about sustainability of energy, of time, of all of those things too. So just be very thoughtful and intentional about all the moves that you make, because again, we need you on the other side of this fight.
Yeah, thank you.
I too was struck by something that Admiral Levine said, and I'm paraphrasing here, and she said it, I'm sure, more artfully than I will, but she basically said, don't be cowed by threats that don't have legal force behind them yet. That is what those that are making those threats want us to do. They want to ensure compliance. They want people to cower in fear and to stop doing the important work that folks are doing. And look, there's a place for lawyers in this too, thankfully or unthankfully, right? And you've seen already a number of the directives coming out of Washington, D.C. be challenged in court by nonprofit groups, state attorneys generals, and others, and a number of them have been frozen. And these are things that do carry legal threats with them, right? But look, if it goes up to the Supreme Court and the law is the law, I agree with Admiral Levine on that. We got to follow the law. But until then, keep doing the work. Keep showing up to work. Keep fighting for what you believe in. Lawyers will be lawyering, right, all the while. And some of this stuff really is just about trying to change the vibes so that people feel afraid to do the important work that they should be doing. And if we just give in to that, they win without a fight. So keep doing the work is the most important thing that I can say, and what I hope everybody, in this field in particular, this crucial field, continues to do.
Yeah, I really appreciate that. The keep doing the work mantra, I think, really resonates. And I think a lot of the work that all of you really focus on is think around issues of gender and mental health equity. And so this is also a topic that came up often with our registrants, and really thinking about what ways does gender identity influence mental health access and treatment, and what initiatives are really effective in improving outcomes. So maybe I'll throw this one to Dr. Watkins to start. Could you start us off and share some of your experience?
Yeah, sure. So we know that there are long-standing systemic inequities in healthcare access and quality that disproportionately impact historically marginalized groups. I think that's what we all are here to try to unpack, particularly women and people of color. But I also want to highlight the unique challenges faced by Black men in particular when it comes to mental health stigma, because it's so important for us to think about what I like to call culturally sensitive, gender-specific, and age-appropriate care. So this is where we have to think about interventions, specifically targeting certain groups. And I want to sort of duck in case the epidemiologists in the room want to throw tomatoes at me, because I'm going to talk specifically about, while there is a place for that work, and we need that work, for those of us who want to do intervention, sometimes we have to be a little bit more narrow in our focus as well. And so, so I think there are things that we can be doing. There are a lot of folks right here on campus who are doing some really fantastic work around interventions. I'm just a little bit biased, but there is this program called the Young Black Men, Masculinities and Mental Health Project, or YBMen for short, that specifically uses social media and actually in-person meetings as well to promote mental health for Black men and boys all across the country. We have a site in Australia, also have a site in Toronto, Canada. And so that's just an example of something that we see that's culturally sensitive, age-specific, and gender appropriate. And so I think it's very important for us to think about those nuances that we sometimes miss out on when it comes to actually making a difference and developing something that can actually make an impact beyond our research.
That's fantastic. Any other thoughts about gender mental health impacts and where we've really seen effective interventions?
I think when we think about gender responsiveness, I think that's important in terms of trans, communities specifically. I think that, Dr. Levine said for folks who wish to access and would like to access gender affirming care, that is life-saving, right? That is a mental health intervention. If you look at the effects for the studies that we've seen, they're actually like on par with some of our other like CBT type interventions that we would see, for example, to treat depression. So I would say that. You know, the other piece is like for trans people, I think in terms of mental health, you know, there are experiences that that are sort of shared stressors with other populations, right? So it could be things like, you know, poverty or, you know, cost, et cetera. Certainly, you know, racism in terms of thinking about intersectionality. There are also trans-specific stressors, right? So those are the things that are somewhat driving disparities, and those can be things like, for example, transgender-specific intimate partner violence, right? That's wielded specifically as a tactic by partners, and it's about, you know, control around trans identity. So, you know, so it's important to understand the both and address those things specifically. You know, I will say on a personal note, like as a person of trans experience, I feel like where we are right now in terms of mental health, it's a throwback. I transitioned, you know, in 1999, and we are like in a throwback right now. Like I don't even know what is happening. So, you know, but I will say that like it's very difficult when sort of rights are taken away once you have rights. You know, it's very painful. You know, and in 1999, it wasn't the same thing, right? Everything was out of pocket. There was no insurance covering anything. It was very hard to find providers and all these kinds of things. So I don't wish that anybody go through that. And we can go through that. You know, we could get through this. And I think that trans communities, from a mental health perspective, we really need to lean into each other right now. And we really need to lean into allies too. Like we really need to come together. So, you know, just share that as well.
Yeah, thank you.
The only thing I will add briefly to this discussion is just to circle back to the point I made in introduction, which is the intersection between mental health and future victimization of crime. Because what the data shows us is that those who have mental health issues are significantly more likely to be victims of crime. And transgender population is also independently significantly more likely to be victims of crime. So when we deny mental health interventions such as gender affirming care, but also just simply allow for discrimination in the healthcare system, we are exacerbating the risk for an already vulnerable community that they are going to become a victim of a crime, and a victim of a violent crime at that. So again, the idea that denying health care doesn't have significant downstream consequences. We see the downstream consequences in the courts day in and day out. And it's, I think, an important point to emphasize that this is certainly about basic humanity, certainly about access to health care and all of that stuff. But mental health interventions that are available to everybody is also a public safety intervention.
Yeah, I think that's really well said. And I think as people were sort of like registering for this and gathering their thoughts, there was also a lot of concern amongst the community about how can we best protect and support the transgender and non-binary members of our community. And so maybe starting with Dr. Reisner on this one, like what do you view as some of the most significant healthcare access barriers faced by transgender and non-binary people? And are there strategies at the policy level or even at the grassroots level you can see that help address these barriers?
I mean, there are so many. You know, I think certainly I mentioned, I mean, if you think about this in sort of multiple levels, right, the individual, interpersonal, and structural levels, you know, certainly I think, and, you know, even tying back to the mental health piece, you know, there is a legacy, as I mentioned before, of medicalization and sort of like the psychiatric part of gender identity being a mental health, quote unquote, diagnosis, right? And the pushing back on that and the advocating for that to be moved and, you know, to think of this as more of a sort of medical issue, right, or something that might be better addressed outside of psychiatry. You know, so I think when we're thinking about access barriers, you know, that's certainly one of them. And Dean Bowman mentioned trust. You know, trust is a major barrier. You know, we can also think sort of interpersonally, you know, about sort of systems that are in place for people. You know, so for example, like, you know, when we're even talking about access to gender affirming care, but there's also, you know, people not having people to take care of them, right? Like aftercare or, you know, community, you know, support, family support is a huge one. So, you know, when we think about interpersonal processes like bullying, or when we think about family support, you know, those things are protective. So, and they're also very important for healthcare access. So, so, and then of course we have this larger policy context that we're working in. So, I definitely don't have solutions. I will say that there are better data, and I think that we need more information to really flood the current era of misinformation and disinformation with some good science. And as far as sort of care access, one big thing is, that the suicide attempt rates and ideation rates are extremely high in trans communities. They were already high, and I'm afraid that they're going to be higher. And I have a study that's a suicide prevention trial right now, testing an intervention to reduce suicide risk in 18 to 24-year-old trans folks, and I'm using that word inclusively, by the way. So I think we need to find more solutions of what works. But we know that policies work, right? There was this great study in Human Nature Behavior that came out just at the end of 2024 by Lee and colleagues, and it was looking at states that introduced, anti-trans laws between 2018 and 2024. It was 5 waves of data. They used this fancy difference in difference approach, which we all love. What they found is that the 13 to 17-year-olds, there was a increase in the incidence of past year suicide by 7% to 72%, depending on where they were, comparing those who were in states that passed the law versus not. And then among 13 to 24s, it was 25 to 27%. So we're talking about a 25 to 27% increase in incidence in this causal sort of design, looking longitudinally in the time after the passing of a law. So it's a very strong design and a very strong study to show us that, that the really negative impacts potentially causally, that we can say. So I think we need to strengthen that piece right now. I'm putting my research out right now, so yeah.
Thanks. Yeah.
I thought that was incredibly comprehensive. I have nothing to add.
Ditto.
I think very well said. I think people are also interested in policy from the other direction, right? So policies that we can use to protect and enhance health equity, and really thinking about successful legislative approaches to do this. So maybe I'll start with Mr. Savitz on this one. Could you tell us a little bit about how differences in local or state policy influence gender equity in healthcare? And then are there some examples which demonstrate particularly promising legislative approaches?
Ooh, that's a
Heavy.
50-state survey type of question here. But look, I mean, there's some obvious differences in states' approach, and really I want to focus on the state level here because I do think that that's where primarily these types of policies are made. But let's start with the obvious one, right? You want to talk about gender equity, and there's a bunch of states where reproductive care is illegal right now. That is not a particularly good gender equity-based approach, in my view, because people die when they are unable to access reproductive care, and that's something that you've seen. You've seen death. You've seen severe injury in states where abortion is criminalized, particularly where there is no exception for the health of the pregnant person, so I guess a obvious legislative approach is legalize reproductive care in your state, just as it was for a half a century prior to the Dobbs decision. But beyond that, states have a lot of leeway under relevant health care laws, including Medicaid, as to what they can require to be covered and not to be covered. We talk about in the abortion context, like the specter of a criminal law being brought down on somebody who engages in a health care choice. And you're seeing that as well in the gender-affirming care context for minors. But that's actually the exception. It's pretty rare, with the exception of those two specific laws, that you're going to have a criminal law against a generally accepted medical practice. But that doesn't mean that care is available, because you've got to have insurance coverage to be able to pay for it. So, for example, even in Michigan, right, where we passed the Reproductive Freedom for All initiative, right, that constitutionally allows the right to an abortion and all sorts of other reproductive care, it is still not yet the case that Medicaid in Michigan covers abortion. And Medicaid, of course, is for lower income folks, which means that that is not care that's as readily available depending on of course, sex, but also depending on socioeconomic status. Now that law is being challenged by the ACLU of Michigan, so maybe in a year's time, this will be different. Beyond that, a number of states do not cover fertility treatments through either Medicaid or by imposing requirements that private insurance cover fertility treatments. These are choices that a state can make, and in the states that, frankly have covered the full panoply of choices that people might make respecting fertility with respect to reproductive rights, they have better outcomes, right? Because it's not just legal, but it's actually accessible. I can go on about this, but one thing I do want to flag in the current environment is that a lot of this is ultimately subject to federal preemption, which means that if the feds pass a law then that prohibits states from making certain choices, that is preempted. And one thing that I am worried about in terms of, and I know you asked about good legislative choices, and I keep talking about bad ones, but I'm worried about, okay, we made a good legislative choice recently in Michigan when we got rid of our Medicaid work requirements that was blocked anyway by a court, and the Biden administration didn't put them into effect. But I'm worried because the Trump administration has announced that it intends to promote in states and perhaps require work requirements for Medicaid. This is not just in order to get certain types of care that is covered by Medicaid. It's whether you get health care insurance at all. And what we know about work requirements for Medicaid is that they do not work. They do not suddenly motivate people to go and get jobs, right? It's not like people are just sitting at home. Oftentimes, you may be a caregiver, and you want to talk about gender equity, that is a burden that falls more heavily on women. And if you are a caregiver and you can't work, and because you are a caregiver, you are denied access to Medicaid, you are denied access to health insurance, the cascading effects really radiate outwards, and they're going to land at the doorstep, ultimately, of prosecutors and judges, right, like me, because healthy families are the best crime prevention tool that we have. Beyond that, I'll just say Medicaid work requirements are not in any way, shape, or form equitable. I actually did write this. Okay, maybe this is why you invited me to be up here. I actually did write a piece about this back in 2018 when Michigan was considering them. But if you look at places like Detroit and Flint, where there's there's higher unemployment rates, fewer jobs available, and also you have to travel relatively long distances in order to get jobs and to look for work, and in a car-dependent state like Michigan, you're raising the burden on people, disproportionately black communities, to get Medicaid, to find work, right? It's harder for them to do so, which is inequitable if you're going to be imposing this supposedly neutral Medicaid work requirement. So there's a whole host of issues with that. So while there are a variety of good state approaches and bad state approaches, one thing to keep an eye on is federal preemption, what the federal government is going to be doing, not just with work requirements, but with respect to so much else with Medicaid plans and its other hooks. That was a long answer, sorry.
No, that's what we were looking for, was that perspective. I don't know, do other panelists have anything else to add there? No? I do have a sort of a follow-up question as we're thinking about sort of equity and access to care and health outcomes, and folks were really interested in learning more about intersectionality and how gender disparities in healthcare might intersect with race or socioeconomic status or other identity factors to produce really compounded effects on health outcomes. I'm wondering if any of you can speak to your own work or what you've seen with respect to sort of intersections across different identities.
I can start, yeah. And so I'm so glad you brought up intersectionality, because I feel like I spend a lot of time in my classes trying to dispel the myths around intersectionality and how a lot of people think it's just the intersections of our various identities, however number of we see ourselves as race, gender, income, whatever. But it's not that. We know that there are systems and structures at play that use intersecting identities as a vehicle for oppression, for discrimination, for vulnerability. And so I think sometimes the systems conversation gets left off of our conversations about intersectionality because it's so much more than multiple identities. It's the systems at play that let us know that, hey, because of these multiple identities, now here are the things we're gonna put onto you that's gonna prevent you from succeeding in life, being healthy, accessing care, accessing criminal or judicial systems and things like that. But it's just so much bigger than that. And so that's why it's very difficult for me to think about just gender equity without thinking about other identities as well, right? Like I think there's so many various intersections that it's hard for me to parse them out, and I'm sure others feel the same as well. But your question was exactly how can we think about that?
Yeah.
Is that what it was? It's just, okay, well, the first thing that popped in my head, which I don't know if it's gonna be a good answer or not, but the first thing that popped in my head was, I think it's so important for us to talk to so many people who don't look like us, right? Because we all go through life with various challenges, and sometimes we don't always acknowledge our privileges. And sometimes growing up or having various challenges as a young person, we tend to ascend to higher heights in life and still hold on to those challenges, not realizing that people actually see us as more privileged than we actually think that we are. And so it's so important for us to lean into, this is who I am, this is how I see myself, but let me talk to this person who's across the room who I would never talk to otherwise. Let me go introduce myself, let me learn about their journey, let me figure out exactly what's going on with them and why they're here, why they're passionate about the work. And it sounds so simple, but I can't tell you how infrequently this is done. We tend to gravitate so much to people who look like us or who we think are similar to us. And so I think once we can kind of parse through all these different intersections and kind of understand whether we're aggregating or disaggregating them, I think that sort of unpacking process is a process that people often skip in this quest to understand intersectionality and how it actually plays out with the systems at play.
Thanks. That's really well said. Any other thoughts from the panelists?
But you asked if there was sort of example research.
Yeah, like maybe from your, from your own work.
I don't know.
Yeah.
I think, it's absolutely the systemic piece of this that is the vital part. And I was thinking of a study that we did called the Light Study with colleagues at Hopkins. And so we recruited and enrolled a cohort of trans women and trans feminine people, 1,500 in the eastern and southern US. And the grant aims were really to look at HIV incidence and to explore vulnerabilities. And about a year into the cohort, what happened is we started hearing from word of mouth in our communities about high rates of death and mortality and people passing away. And so we have a community advisory board who were saying, you're talking to us about HIV and we have a lot of other things going on and this is not our primary thing that we're really interested in. And disproportionately, we see the data that show that Black and brown trans women and trans feminine people have high rates of mortality. So anyway, we ended up sort of pivoting our protocol a little bit to collect and ascertain deaths in the cohort. And so our primary sort of findings paper, was in the Lancet HIV that was both incidence rates and mortality rates, showing differential risk for those who are trans women of color. And so the thing that I'm saying here is that the systems, as you were saying, of oppression are driving multiple health outcomes, right? It's not a single health outcome along the axes of both, gender as well as race and ethnicity. And so, and I should say racism. So anyway, that's just sort of an example. And I think that attending to that and bringing in community to tell us about this, because we wouldn't have asked that question, that wasn't the question we were asking. And so bringing in community to tell us, this is the question we want you to answer, I think really can help expand what are intersectional questions that we might be able to explore further.
I'll actually jump in. I'm going to go out of order here because something else popped in my head. But I was just sitting here thinking about how, it's so important for us to evolve as researchers, as practitioners, in our careers as professionals, particularly because when I first started out doing work with and in service of Black men, I thought about my own experiences and I said, okay, let me create interventions that's going to help Black men, that's going to help Black men. And then I feel like 20 years later, I'm looking at my work and thinking, they don't need the help. We need to be trying to change the systems so that, the systems now understand black men. And so by they don't need the help, I don't mean we shouldn't do anything, but I mean sometimes in our training, we feel like we get all this education, we have all this knowledge, we go to these communities of color, these marginalized groups, and we say, I'm here to help you, not realizing that a lot of our energies need to be put towards the systems and the structures at play, because we don't need to change anything about them. There's nothing wrong with them. There's a lot wrong with the systems. And so I feel like this journey for me has been one of enlightenment and evolution in that, man, not that I had it wrong back then, I think I did pretty good back then, but that I'm thankful for evolution and thought leadership around, how does our work look over the course of our careers, right? We choose a profession, we choose a topic to study, but then are we pivoting when the world pivots? When COVID-19 happens, how many of us pivoted? When the racial reckoning of 2020 happened, how many of us pivoted? And sometimes we get so steadfast on this is what I'm gonna do, I wanna be an expert in this, I'm committed to this, I'm doing my dissertation on this topic, so I can't change, instead of realizing there has to be constant evolution in what we do if we're really going to make the differences that we say we want to make on this world.
Yeah, I think I want to follow up on this a little bit, thinking about the work that we do that's public facing and community engaged. I think that's something that all the panelists do a lot of really important work on. And if we're dealing with these complex issues, right, it takes like interdisciplinary work between academics and legislators, folks in government, public health professionals, community leaders. I was hoping that each of you could talk a little bit about your strategies to do this type of interdisciplinary community-driven work. And if there's like any lessons learned or recommendations for this like next generation of public health professionals that you've taken away from doing this type of community engaged work.
Okay, I'm fired up now, so I'm
No,
gonna
good,
start.
great, excellent.
Getting comfortable now. So I'm so glad you asked about the interdisciplinary piece, because I sort of jokingly tell people I'm the queen of interdisciplinary work. Only because I have a PhD in public health. My undergraduate degree was in anthropology. When I came here to Michigan to do a postdoc, it was in social psychology. I had a faculty appointment in psychiatry, and I'm a professor in the School of Social Work. And so I know that was a lot. And I'll say, I remember when I started this journey to really commit my career to helping black men, doing work with and in service of black men, I remember telling people, I want to be the expert in black men's mental health, period. I don't want to be the expert in social work or psychology or public health. Like, I want to read everything there is to know about this topic. And I think sometimes as educators, we sometimes tell our students, well, you're a public health student, you're a social work student, make sure you study all the literature in our discipline. And that's exactly the opposite of what I tell my students. Like, if you really want to know a topic, read everything there is to know on that topic, because that way you can be bilingual, trilingual, you can talk across different disciplines and fields, you can go to conferences, you can write in different journals, and I think that sometimes is missed in our training programs. The importance of, we have to be able to sit at the same table with people who were not trained like we were. And how else are we gonna have an open mind and be receptive of what they have to offer unless we really value and respect what they have to offer? And so that approach was definitely met with a lot of opposition, but I think for me, it was so much about just making sure that I made a difference in whatever room I stepped into. And so, of course, there was a little bit of career identity. People didn't know who I was. Are you a psychologist? Are you a public health professional? But instead of focusing on who I was, I told them what I did. Let me say that one more time. Instead of focusing on who I was, I told them what I did. And that opened up the conversation in ways that me saying I'm a public health student, I'm a social work professor, whatever the case may be, that opened up the conversation in ways that I don't think I ever could have if I told them who I was.
I loved all that. I'll offer a perspective sort of from on the ground in my day-to-day work and our day-to-day work in the prosecutor's office. One of the things that I ran on is that we need to be treating a lot of stuff less like a criminal issue that requires punishment and more like a health issue that requires treatment and rehabilitation. And by that I mean, we can throw somebody in jail for a lower level offense for 30 days or something like that. But if it was a mental health issue or a substance use issue that got them into there and that place in the first place, if we haven't addressed that core issue, they're going to be right back out, probably doing it again, and we're going to send them to jail again, and then we're going to, it's going to lead to housing instability and work instability, and then they're going to be even more desperate, and the cycle is just going to continue and possibly exacerbate. So I believe that for a whole host of stuff, we do better, both from a fairness perspective and from a public safety perspective, at trying to get somebody help and resources and requiring as accountability, right? If you've got a mental health issue, you've got to participate in a program. If you've got a substance use issue, you've got to do the hard work towards recovery, right? And if we do that, and they're successful at it, what do we got to impose punishment for? Haven't we done our job? But I got to say, like, this is a thing that is, it's not like I made it up. It's been said multiple times by many, many people over the years when you talk about the failures of the war on drugs and the like. And we say we should be treating this more like a health issue and not like a criminal issue. And I agree with that, but also when you say we, who's we? I can't treat anything like a health issue. Like, again, I'm surprised to even be up here. I don't got a doctor in front of my name. Like, I'm a lawyer. You don't want me doing anything related to physical health or mental health. I'm just not trained for it, right? So that's where we need to have these conversations and build these partnerships. And so we have a really close working relationship with, for example, community mental health here and various substance use service providers, as well as our law enforcement partners, like the Sheriff's Office. We have a program here now called the Law Enforcement Assisted Diversion and Deflection Program, where for lower level offenses, law enforcement on the ground can refer somebody to mental health, behavioral health intake, and that's all that's demanded is they go to that initial intake session. And if you do that, we won't bring the criminal charges. And these are folks, oftentimes, that have been in and out of jail hundreds of times. I mean, like, I'm not exaggerating here, hundreds of times. And that simple intervention to say, all we're asking you to do is go to this intake appointment with a caseworker can actually be transformative. And this stuff works too. I mean, we have partnerships, again, with providers of mental health, substance use services, and we allow people to go through those services without even pleading guilty to a crime. And if they complete it successfully, case is totally dismissed. We got this program, it's called our pre-plea diversion program. And you know what the recidivism rate is for that? You guys aren't going to believe me when I tell you. For people that successfully complete the program, it's 0%. Wow. It's not going to stay 0% forever, but it is now, so I'm going to keep bragging about it for time being. But when I say bragging about it, all we did was take a step back. And we needed to have the conversations and listen to providers and try to secure funding so that folks had a place to go outside the criminal system. That's a type of interdisciplinary work, not just that facilitates better conversations, but that really changes lives, because you can't rely on the government, you can't rely on the courts, you can't rely on the justice system, you can't even rely on providers to do it alone. We've all got to be working together from the same playbook, bring our own individual expertise to bear.
So one thing that I'll comment on that, or one thing that came to mind after you said that was, it reminds me that for so long we've used that term trauma-informed care, and Sean Jenwright doesn't like that term. He actually calls it healing-centered care. And the first time I heard that, I said, that's exactly, I mean, to me, that's what you just described. Instead of looking at it as trauma-informed, how are we centering healing in the people who come into our world? And so I just wanted to kudos for that. Instead of trauma-informed, healing-centered care. Sean Jenwright, he writes a lot about that, so you should look it up. It's good.
It's a nice way to reframe, yeah.
I was thinking as you were talking about sort of coalition building, and I mean, I've talked to more lawyers in the last month than I've ever talked to in my entire life. No offense, and I was like, I didn't know there were so many. Actually, it's like, phone a friend kind of situation. You know what I mean? Who's your lifeline? That's how it's been. But we had a project in I do work in Latin America, and we had a project that was actually funded by the Department of State. This was in 2015, and it was a human rights violation and reporting and response network that we formed, focused on people of trans experience and with trans experience. And the first time that I went there, we sat down, and one of our team members was an anthropologist, and she had us do this strategic mapping exercise, and it just sort of like blew me away the way, I don't know, it was something about the visual way that we were mapping the organizations, the entities that needed to be involved, you know, and there we were really working a lot with the state, and also kind of where we could find services. And I mean, it just blew me away. And then we did that mapping exercise every year because we saw the landscape change so much every year, right? So it was a way for us to see like who is at the table that we would like to collaborate with and who isn't, and who do we need to bring in, and also like where are the gaps in this landscape in this particular time and place. It was in Peru, you know, in 2015, like where were those gaps, you know? And it also was especially helpful because the system there, like in terms of the volatility of the political system, it's very volatile. It changes very often. And so I feel like there's definitely some lessons learned. I've been thinking about that and the way that those maps changed. Maybe right now we need to do the maps like every 4 days, but but it's a helpful, I think, tool. So anyway, that was sort of combining the need for interdisciplinarity, like learning and staying open to new methods and ways and people and organizations that could come into our lives. And I think when we come together across disciplines, we just come up with new solutions that we wouldn't have come up with by ourselves. You know what I mean? 100% of the time. So yeah.
I think that's really well said, and really like highlights the strength of all of us working together on these complex issues. I think that might be where we leave it today. I think it's a really good place to end it. So please help me thank our panelists for outstanding discussion, very inspirational, and thank everyone for attending today's event. So for those of us that are here in person, we would like to invite you over to the Vandenberg Room down the hall for food and fellowship. Thank you all again for attending. Thank you.